Welcome to our EASD coverage. Ms. Lee from the University of Cambridge in the UK had a presentation about the topic Ethnic-Specific Associations of Predefined Dietary Patterns with Type 2 Diabetes. In the following, she will summarize the key points of her presentation.
So we know that following healthy diets could lower our risk of getting type 2 diabetes, but what the question we had in mind is whether this protective benefit is the same across different ethnic groups, because we know that the burden of type 2 diabetes across ethnic groups differs significantly, and also different ethnic groups might consume very different diets. Even if you ask them to follow the same kind of diet, they might actually consume very different foods depending on the cooking method, food availability, as well as the social cultural factors, which is why we aim to systematically review all the available evidence out there by doing this review and to pull together the results to compare whether there is a difference in this benefit of diet in terms of type 2 diabetes prevention across the ethnic groups. So in our results, we identified studies from about 1 million individuals across 7 dietary patterns, which includes the Mediterranean diet, which is characterized by high olive oil. We have the alternative healthy eating index, which is commonly used in research that is known to be protective against chronic disease risk. There is also the DASH diet, which is known for lowering the blood pressure, and the healthy eating index, which is based on the US dietary guidelines as well as several plant-based dietary patterns. So in all the meta-analysis that we have done, all these dietary patterns, they were protective against type 2 diabetes incidence, and this protective association did not differ across ethnic groups, which means that based on the results it shows that following these diets are equally beneficial for people of European, African, Asian, Hispanic, and some other origins. So, that is the main finding of our study.
Perfect. You, in the end of your presentation, you showed us the limitations.
Yes.
Can you elaborate a little bit on that?
Yes, so first of all, because we were looking at type 2 diabetes incidence, which is newly diagnosed cases as an outcome, it is extremely difficult to conduct trials on this topic. Therefore, almost all of the evidence was from observational studies, so that would lower the strength of causality, because you are not really asking people to change their diets, and their diets might be affected by many different factors, which is known as confounding. But the other factors would be we categorized the participants based on their ethnic groups into 4 very broad groups, and these groups may not really fully reflect the heterogeneity within, because we know among Asians, East Asians and South Asians are very different, and also within Europeans there's quite a diversity as well. So that is limited by the existing data, because there's simply not enough studies in each ethnic group to really compare these in detail. And one very important point to consider is also that these dietary patterns were captured based on predefined scores, which generally are based on food consumption, but they do not capture things like cooking methods, or they might not capture the very cultural, ethnic specific foods. So even though 2 people, they score the same on the dietary pattern scale, what they consume might still be very different. And this is something that future studies might want to consider, which is dietary assessment in different ethnic groups, whether we could improve that, is there any room for improvement, and how would that translate into the length of diet and clinical outcomes.
And in your personal opinion, what do you think would be the next steps in this research topic to more go to this ethnic dietary associations?
Yeah, I think firstly, what I mentioned earlier, is to understand better how we can better measure the diets in different ethnic groups. And then it's also to look into more understudied populations, because in our study, even though there's 1 million individuals, there's more than half of them are from the US and Europe, which is predominantly based on white European origin individuals. So even though we have tried our best to gather all the available data, there's simply no data in some regions like in native Africa or in South America. So those are important gaps to be bridged because these dietary patterns have been recommended by many well-known international organizations, but still it's not based on a very globally diverse set of data.
Thank you very much and good luck with your research.
Thank you.